one of the R3s, and I'm in the clinician educator pathway, which is how I got signed up to do an academic half day today. And today we're going to talk about outside hospitals, the OSH, this entity that we all reference in our documentation. And let's see, that's really all, because it was something that seemed interesting and like a big zoom out from talking about like really zoomed in endocrine stuff all morning long. I have no particular disclosures. So I put these sort of pictures in here because I think like really my interest in this topic, I grew up in Alaska and sort of like rural healthcare systems and like how small hospitals fit into healthcare systems is interesting to me, which is why I just started trying to learn about this stuff. This photo is from a village called Kalskag, which is the like red and yellow dot on the map of Alaska. It's on the Kuskokwim River. I was out there, I think it was like 2016 or so. I was out there like teaching kids to cross country ski, but it's super windy. There was no snow that year. So the only place we had to ski was on the river itself, which is like the frozen surface in this photo. And we were skiing with, I think it was like the second graders or the third graders, but like skiing on just literally a sheet of ice when one of them fell and hurt his ankle like so bad that he couldn't walk. And so we ended up having to like carry him back to the village. This is a village of about 200 people that does not have like a healthcare facility per se. It has like a rural health clinic. And so we like carried him back to the clinic, and there was a community health aide there who was like, I don't know, like he probably needs an x-ray, but we're in Kalskag, which does not have an x-ray machine. So this kid ended up spending the night in the clinic until he could get put on a plane the next day and flown to Bethel to get an ankle x-ray, which was negative. And then he got flown back to Kalskag and resumed skiing with us like the next day because he's a third grader and he just rebounds like that. So anyway, I think that, like these sort of like ways that people have to access care and where care is located, particularly in these really remote locations, is interesting to me, in part because of experiences like this, where I was like, I think it was pre-medical school at the time, but it was sort of a mind-boggling experience to have to get on a plane to go get an ankle x-ray and come back. But I have no actual knowledge about this. And I know that there are some people from our health systems pathway who are here today. And I know that Dr. Cho is a health systems expert. And so if people feel inclined to chime in at any point, please feel more than free. The outline for today. So we're just going to sort of briefly go through like a history of hospitals in our country in a very, very broad overview way, because that's a long and detailed history, as it turns out. Get a little bit into sort of who runs the hospitals and how do they get paid. And this is all a little bit with an eye specifically towards rural hospitals and what is a critical access hospital. And then we're going to spend a little bit of time. I'm hoping we're going to have maybe like 15 or 20 minutes to get into breakout rooms and have you guys learn about some of our more rural critical access or community like local hospitals, so that we can then come back and sort of share what we found about how these places are serving our patients. Our objectives, I just want you guys to know like a little bit more historical and societal context for current hospitals in our country. That's what I've gotten out of learning for today's talk. Know a little bit about sort of payment and like how that is relevant, specifically related to Medicare, because I think that's a big piece of this. Consider sort of some of the challenges to operating a rural hospital, and then basically just like develop an appreciation for these OSHs that we reference like that in our documentation. So diving into the abbreviated history of hospitals, going back to like the turn of the 20th century, the early 1900s, basically it sounds like at that point, hospitals were really just like any kind of place where people sort of got collected up to be taken care of. And some of them were private, some were public, some were religious, some were just sort of like places where people put people who society did not want to deal with at the time. And it wasn't until basically during World War II, at the time of kind of the Great Depression, when when physicians wanted to ensure that they were going to get payment for their services, that people started, that basically the first like sort of formal health insurance as we know it got rolled out, and hospitals started getting a little bit more formalized in the way that they existed. There's a couple other sort of interesting historical moments that ended up in this timeline. For instance, the discovery of streptomycin in 1943, because back in the early 20th century, many people who were in hospitals in our country were TB patients. And so once streptomycin came out, there was a way to treat TB patients and a way to start sort of like moving TB patients out of hospitals because there were not so many of them anymore. Then there was sort of some federal acts that allowed for funding to start constructing a lot more rural hospitals, and the number of hospitals in rural areas started going up. The Joint Commission got formed, which added sort of some more like structure and formality to what it meant to be a hospital. Here's another one: when Thorazine came out in 1955, which allowed for, this was like the first antipsychotic. Another major population in the hospitals in the early 20th century were patients with psychiatric illnesses. And so the way that sort of our hospital systems existed and served those patients started to change with sort of this whole deinstitutionalization movement, which could be an academic half day in of itself, probably. And then 1965 was when Medicare and Medicaid got created, which kind of started to, provide for more insurance for more people, and also like change the way that hospitals were being paid. But immediately started spending a lot of money on a lot of hospital care. And so it was in 1987 that am I getting this right? Yes, that Medicare felt it needed to sort of reel in its spending, and start to sort of restructure things by coming out with sort of accommodations for having smaller hospitals, including the designation of a critical access hospital, which has sort of gone through some iterations. And I know that there's been a million things that have happened since then as well, but that's, I think, really the broad overview to get to the point of what I'm hoping we go through today. So that's really the timeline that we'll cover. And if I can get my slides to advance. So looking now at hospitals in our country and sort of like who runs the hospitals, what are the hospitals? I think it's worth saying that the significant majority of hospitals in our country are community hospitals. There are, so basically, like as far as Medicare is concerned, at least, there's the psychiatric hospitals, there's long-term acute care facilities, but in terms of really like medical hospitals, there are federal hospitals and there are community hospitals. And so, for instance, UW, while I think like we all talk about community hospitals, meaning not UW, UW would be a community hospital in this structure because it is not a federal hospital. And federal hospitals are really essentially just the VA and the DOD and then like Indian Health Service hospitals. And amongst those community hospitals, the like 60% of them are operated by nonprofit groups, about 25% are profit groups, and then there's some number like UW that is operated or sort of like managed by state or local government entities. And then, to say that like for rural hospitals in particular, there are a lot of challenges these days. And this graphic is basically just trying to demonstrate that rural hospitals in particular are continuing to close. The actual number of hospitals in our country has decreased pretty dramatically in the last like 40 years. We went from about 7,000 hospitals to now it's like 5,400 or so. But like recently in the last 20, 30 years in particular, a lot of this is being driven by rural hospital closures. And so this is just sort of depicting some of that and then getting at what are some of those challenges to operating a rural hospital, which really have to do with the fact that, much of our US population is kind of changing its demographic of where it lives. And at this point, most patients who live in rural areas tend to be older, have more chronic conditions, be poorer, basically, and more served by Medicare and Medicaid, and probably which are sort of not going to reimburse the hospitals at the same rate that some of our private insurance companies might. And then there's also the real challenges of like training people to work at hospitals. We know that people, us included, like to work in the places where we train, and we don't tend to train people in rural places. So it can be really hard for some of these smaller, more rural facilities to hire people out of like large urban areas and then to get those people to stay. So then to get to critical access hospitals, because I think that this is probably something that we should all know what a critical access hospital is. And so those acts that Medicare came out with in sort of like the 80s, 90s, essentially trying to support having hospitals and healthcare in rural places. Part of what they did was establish critical access hospitals and like try to offer systems of support for these hospitals surviving despite the challenges that we just talked about. So in order to be a critical access hospital, a hospital has to be located in a rural area, which they have sort of some different definitions for, but in general, it's gonna be like more than 35 miles from another hospital. Has to have less than 25 beds, which are with like an average acute care stay that's less than 4 days. They need to be able to offer emergency services 24 hours a day. And basically what they get out of this is that they get sort of an alternate system of receiving payments from Medicare, and they get some more sort of flexibility in some of the standards that Medicare holds hospitals to, as well as sort of some access to like education and grants through Medicare, although from what I saw on the internet, people are none too impressed by those for the most part. So then I think it's important to sort of say, like, how does Medicare normally reimburse hospitals and what is different about this? Very broad strokes, not trying to get into the nitty-gritty of this really messy system. But essentially for most cases, like most acute care hospitals, Medicare sort of decides like an amount of money that should be associated with any given diagnosis, and then tries to take the patients who have been hospitalized and figure out like what diagnosis is appropriate and therefore how much the hospital should be paid for them. And then they also do a whole bunch of adjustments and like potentially some bonuses based on different quality metrics and whether the hospital is a teaching hospital. And there's also actually some other things in here that are for sort of like rural hospitals that don't quite meet the critical access hospital definition, which is interesting too, but I think getting too into the nitty gritty. And really what's different is for critical access hospitals is that they, instead of having to operate off this basis of like what Medicare thinks a diagnosis should be paid at, they sort of get to say like, here is what it costs us to care for a diagnosis, and then get reimbursed for that up to 101%. So they can get sort of a little bit extra on top of that, of like on top of what the actual cost of delivering care for the patient was. Okay, so with that background, let's get to what I'm hoping is like the more fun part of this. If you guys have ever worked with me on an inpatient service, you probably know that one of my favorite things to do is like Google where my patients come from, whether it's their home in Seattle or their home someplace else in the world. And so I'm hoping that we can all spend a little bit of time doing that. Lindsay, you could drop that PDF into the chat at this point, if you don't mind.
Yes, I will go ahead and do that.
Thank you. And so essentially, I think we're going to get out into breakout groups. And if you can try to look, I think when it first puts you in the breakout group, it'll tell you like what your group number is. And basically the PDF that Lindsay just dropped in has a list of some different hospitals in Washington, and you can find like the hospital that corresponds to your group number, and then try to like just go on the Google machine and learn a little bit about the community that this hospital is in and what sort of services the hospital has and sort of like what its challenges might be in existing. And I'm hoping we can all kind of learn a little bit more about Washington and the hospitals that I came up with this list based of names that I recognized as places that I have received patients from. So I'm hoping that this is also giving us a little bit more insight into when we get these patients in the future. And then if you guys want to, in your groups, like try to designate someone to sort of share out basically like anything particularly interesting that you're learning or just any reflections up to the end of this.
All right, are we ready?
Yeah.
All right, is it 15 minutes that we're gonna spend?
Let's do 20.
20, perfect. All right, I'm setting a timer so you'll see it in the corner. All right, away you go.
Awesome. I want to listen in.
Yeah, let me assign you
Great.
to one. Celia, would you like to listen to?
Sure.
Okay, I'll assign you to one. All right.
Cool. So I wonder if some people could share just things that your group learned, anything that really surprised you about your hospitals or communities, or just like reflections from that. And is there anyone from group, I guess we can just kind of start going through. Is there anyone from group 1? Oh, sorry, I'm gonna have to not do this, but that was Skagit Valley.
Sure, yeah, I can talk. We talked in group 1. I guess I was a little surprised by, the amount of services that they had available. Granted, kind of difficult to tell like hours, obviously, that they're open, but at least at Skagit, it's got a cath lab, it's got a level 3 ER, it's got a bunch of sort of different surgical services, so vascular, orthopedics. So I was a little bit impressed, and they have I think 140 beds, don't have the biggest ICU, just a couple of beds. I was actually impressed with sort of the different services that they did have. Again, caveat, don't know kind of the hours of those.
Cool. So it sounds like Skagit Valley is actually like a more substantial facility than some of us may have anticipated.
Yeah, I was sort of joking around that I don't really see why they're sending patients over to UW. It seems like they have a bunch of services there.
On the flip side, think about how many patients they probably aren't sending to UW. How about anyone who looked up Island Hospital? I was listening in on this group for a minute. Does anyone want to share anything interesting that you found?
Yeah, I think we'll kind of echo Yuri's comment too, is just they do have a lot of services, a lot of subspecialty services. I think someone had seen that they're the only hospital in Washington with a top 100 designation in orthopedic surgery. So that was pretty cool. They have a bunch of different services. They've got a nearby SNF, but just one SNF is what we could find in the area. But they are able to do some stuff. They do not have an ICU though, or they have like a tele ICU instead of like having ICU people staffing the patients.
Mm-hmm. How about out in Forks?
We had the Forks area. I think one thing that stood out was the closest dialysis was in Port Angeles, so 40 plus miles away. And just thinking about that being 3 times a week, it's just, yeah, it sounds close for people who live, in Seattle, but like that sounds really far.
Yeah,
and that's where that's where everything is relatively speaking in Port Angeles. So they always have to travel there.
How about Snoqualmie Valley? It's like kind of just up the hill. I feel like I drive past this one all the time.
Yeah, so not terribly far from us, but very, very small. So their inpatient is like only 25 beds. So they have, their staff is one family medicine doctor and like 7 ARNPs, and then one cardiologist and one GI doctor. So pretty small, bare bones, not a ton of specialties, no ICU, no OB. And then like a couple of what they call swing beds for people who were like sort of rehabbing or maybe post-acute, but that was within their 25 beds. So pretty minimal, but obviously close to Seattle. And they did have some SNFs that were pretty close by too, like within 10-minute drive.
Cool. Do you know, are they a critical access hospital? That's the 25 beds is like the cutoff. So that's why I asked.
I am not sure. Did anybody else in my group see if they were like truly critical access?
I feel like based on the other definition of it needs to be rural, like in terms of the hospital distance, it's probably not going to meet that criteria. Just because there's like Swedish, Issaquah, and places that are pretty close by.
Yeah, it feels like those are less than 35 miles. What about Lake Chelan?
That was our group. So this is in Chelan, Washington, which has a population of 4,000. This hospital does advertise very clearly on their website that they are a accredited critical access hospital. They have 2 ED docs. They have 1 family medicine doctor that runs clinic only on Tuesdays, Wednesdays, and Thursdays, and a general surgeon. And interestingly, they have a pain specialist. And then the closest place that has kind of more subspecialty care would be Wenatchee, which is about an hour drive, a little less than an hour drive.
What about Kititus? I don't know how to say this one.
I can do a brief overview for Kittitas. I don't know if that's right either. But it is out in Ellensburg, which is about 90 miles east on I-90. It's a community of about 20,000. It's where Central Washington University is, so that's kind of the main, the largest industry in the area. I'm not sure if it's a critical access hospital or not. They have about 25 to 37 acute care beds, 6 ICU beds. They do have OBGYN services and do about 300 deliveries a year, including C-section capabilities. And then for all the other services, it sounds like kind of in each case, so for nursing homes, there are, looks like 2 in Ellensburg. There's an infusion center in Ellensburg. There's 1 dialysis center there. And then the next closest of all those services would be either Yakima or Wenatchee, which is 30 minutes to an hour away.
How about Astria? Did anyone have Astria? I think we're getting into the last couple here, probably.
Hi, yeah, our group had Astria, which is in Sunnyside, Washington, which is like this town somewhere between Yakima and the Tri-Cities area. It looks like it has about like 16,000 people. Astria does advertise on its website that it is a critical access hospital with 25 beds. We also, I think, commented on the fact that there's like a pretty surprising number of like services here. They have a ED with a level 4 emergency room, an intensive care unit, a level 1 cardiac facility, a birth center, and cancer center, and they do like inpatient surgeries as well. Then like, I think we did find dialysis centers and rehab facilities and like nursing facilities in Sunnyside. And then there's nursing schools and training programs in Sunnyside in Yakima. And then there's a medical school in Yakima. I think the DO program there. So it seems, but Yakima is about a 45-minute drive away. And then for cancer care, it looks like the closest infusion centers are either in Tri-Cities or Yakima, so 45-minute drive.
Mm,
But yeah, more than we expected to find
yeah,
for a fairly small hospital.
yeah. How about Cadleck? Swear, I think we're in the last like one or two of them here. I think we're running out of groups.
I had this. Yeah, just poking around. It actually seems like Cadillac Regional Medical Center is a pretty large hospital, which I was impressed about. They have an ICU with 20 beds. They have an ED. Looks like they do some cancer care. Since a lot has already been covered by other groups, I'll just say one interesting thing I found. They have this whole tab on bloodless medicine and surgery services. So basically trying to provide services to people who don't want to receive blood transfusions for any reason, which I just thought was interesting. It made me wonder a little bit about the demographics of the patients they serve.
Yeah. Okay, I think we really must be either out of places or regardless down to our last couple minutes. So I'm wondering, does anyone like have any just reflections from this? It sounds like overall what I'm hearing is that a lot of people were sort of impressed to find the number of services that some of these hospitals have and are able to offer to people, although there were certainly some small places thrown in that didn't have a lot.
I think you made a good point with the sort of like hours and coverage that I think maybe isn't captured in some of the just like information, or isn't maybe as obvious in some of this kind of the what's on websites and easy to find, and that might contribute to access issues. I just thought that was an interesting point.
Yeah, I actually thought that also, and there was a whole thing that I was reading briefly about the staffing, and there is some like staffing flexibility, but like if you're a critical access hospital, you don't necessarily have to have a nurse on site, like an RN on site all the time, which is crazy, right? The idea of a hospital that like doesn't have an RN on site. It's just sort of an interesting thing to think about some of these other places. Okay, so in our last minute here, I'll just go to sort of my takeaway slide. I think, really what I'm hoping that folks are getting out of today is just like remembering that there are so many hospitals out there that are not a part of our hospital system that do so much for our patients. And while they certainly have their limitations, many of them are really doing a lot for folks. And like, I think oftentimes when we get these transfers, we have a tendency to sort of be like, oh, like this transfer, I don't want to deal with it coming from an OSH. But I think really trying to like remember some compassion for these other places and keep in mind how much they are doing for people who they're not ending up transferring to us. And I personally, there are various people on the internet who go on rants about this, and I would join them, I think, in like thinking about a little bit intentionally when you're doing documentation, the use of that OSH versus like naming a hospital, because I think as we just heard, like not all OSHs are the same. There's like a broad spectrum of what that means to just be a hospital that isn't UW. And so sort of keeping that in mind and thinking about naming a hospital or at least like using an appropriate abbreviation for it other than just the OSH. That's all I got.
Awesome. Thank you so much, Celia. That was super interesting. I like want to go read about all the other hospitals now. And I know there's like so many more out there. But thanks everybody for your participation today in Academic Half Day. Got some endocrine pearls, got some outside hospital pearls. And I hope that you all have a wonderful rest of your day. Maybe Celia, if you want to hang out for a couple minutes in case folks have any questions. But otherwise, good to see y'all.